So I appreciate the opportunity to talk about renal replacement therapy, and was reflecting on my talk last year thinking, if is this a graduation or is this a penalty? But in the context of working with a strong team and really leveraging our nephrology colleagues' expertise, it's really a privilege. And I will highlight this is from a heart failure cardiologist perspective. So my aims are to define the prevalence and clinical implications of needing to use renal replacement therapy in this specific patient population, focusing on AMI cardiogenic shock. Talk about renal replacement therapy options, and highlight in a very practical overview way management goals and challenges. So this was really, in the first talk reviewed, the extreme cardiorenal dysfunction relates to both congestion, and in those with cardiogenic shock that's more severe, a compromise in arterial filling. But I think we as cardiologists and the team taking care of these patients need to really reflect on the importance of venous congestion. So this was reviewed just now, and my colleagues from Cleveland Clinic, Wilson Tang and colleagues, really highlighted nicely that even in the presence of good cardiac index, those with the highest CVP had the worst worsening of renal function. And when you look at what's happening at the renal parenchymal vein level by using Doppler, where continuous flow is more of the normal, there's a transition to biphasic flow and monophasic flow. And we as cardiologists commonly look at diastolic predominance in the hepatic vein, or look at the right-sided restrictive physiology by echo. And I think the reality is that those patients that have venous congestion to a degree where they have monophasic flow, they have the highest events, if you will, in terms of adverse outcome. And in those with more overt shock, where there's really a paucity of literature, but compromised arterial filling, low cardiac output, plus venous congestion, I really think sets up the stage for what we see in terms of progression with hypotension, acid-base disturbance, and electrolyte problems. And so I want to review just a few studies, and this comes from the Danish cohort study from 2005-2012, acute kidney injury treated with renal replacement therapy, really a deeper dive, if you will, both in terms of prevalence and outcome. And in this patient population of over 5,000 patients, there's a prevalence of around 13% had acute kidney injury and renal replacement therapy in the setting of shock. And compared to those that did not need renal replacement therapy, twofold increase in in-hospital mortality and a 50% increase in mortality at 5 years. Certainly those needing renal replacement therapy are a sicker cohort, and a greater percentage of them needing chronic dialysis. This is a nice study from our colleagues from Italy, 2005 to 2015, AMI, NSHOC, and renal replacement therapy. While a lower prevalence, they did a good job of identifying those risk factors associated with needing to use renal replacement therapy. Older age, diabetes, hypertension, I think we would have potentially hypothesized. And certainly those with a lower LVEF. But cardiogenic shock in and of itself carries a high odds ratio in terms of needing to use renal replacement therapy and in-hospital mortality. And it's the company it keeps, and I put forth those other variables which really associate with good degree, when you look at the AUC curves, when these patients have a variety of these parameters in the presence of shock, high association with not only need for renal replacement therapy, but for in-house mortality. So taking a step back, what is our goal with replacement therapy? And it's, in my mind, to really replace most of what the normal kidney is doing, related to water handling, solute clearance, and important restoration of the acid-base underlying disturbance. So the accepted indications, this was brought up, refractory volume overload, I think we certainly see a lot. But when we start to see that coupled with metabolic acid disturbance, and I don't think we need to wait to a pH of less than 7.1, I think there's an opportunity to act perhaps more proactively to help these patients. Again, really a lack of data to help define that comment. But in terms of the multiple modalities, intermittent hemodialysis, I think we're all used to, continuous renal replacement, so continuous veno-venous hemofiltration versus CVV HD compared to other hybrid modalities. And I think that we all recognize this, that CRT does position us in this patient population shock to offer better hemodynamic stability related to the slower solute and volume removal, less fluid shifting from a volume and osmolarity perspective, more consistent net salt and water removal. Possibly not proven, perhaps maybe more with convection versus diffusion, an opportunity to clear some of the inflammatory mediators or cardiac depressant factors in patients with this syndrome. But again, really no data to suggest that. So CVVH versus CVHD, not to get into the details related to convection and diffusion, but CVHD does not require replacement therapy as opposed to substitution solution to CVH. But I think the take-home message is if there are disturbances in pH or electrolyte imbalance plus fluid overload, we're using one of these two modalities. That's different from slow continuous ultrafiltration or ultrafiltration by means of the aqueducts device, where really the indication here is to treat volume overload. It is based on convection, but with no underlying need for pH correction or waste product removal. So just a couple of comments on ultrafiltration. I put in quotes for the heart failure specialists. Smaller amount of venous access that's required, 10 to 40 cc's of blood removed, works by means of a pressure gradient across the membrane. And the fluid removal is at a rate where hopefully there will be naturally recruited fluid from the tissue, and we want to avoid the plasma refill rate. And our concern is in those with perhaps not as much fluid on board is exceeding that and creating a source of hypotension. So here's the comparison between aquapheresis and CVVH, and we as providers or specialists of heart failure can manage the blood withdrawal rate. What's nice is that we get ultrafiltrate that's isotonic compared to hypotonic, so more bang for your buck compared to pharmacologic treatment. The hemodynamics in a non-shock cohort are impressive in terms of reducing filling pressures and not at the expense of cardiac output. And the CREST trial was alluded to, a covariate endpoint, and the take-home message is that there was no significant weight reduction when you compared pharmacologic therapy versus ultrafiltration, and more renal preservation, if you will, with the use of medicines. Serum creatinine at 96 hours was higher than compared to those treated with medicines. And we did, in treating these patients, we were part of this Houston Methodist and Baylor, we considered dopamine and dobutamine in a subset that had refractory volume overload and poor urine output, but it was not a shock patient population. And most importantly, death or serious adverse events was higher in those we were using ultrafiltration in this select patient population. A paucity of data related to slow continuous ultrafiltration, but in an advanced heart failure cohort, high incidence of subsequent transition to needing true renal replacement therapy, and in those particular patients, an in-house mortality as high as 40%. So CRT considerations in shock, certainly vascular access is important. We want to maintain that form of therapy. Anticoagulation, I think, is the standard. The prescription I've alluded to. Timing, not a lot of data. And this is just a snapshot, small trial, 15 patients in Taiwan, where early use of renal replacement therapy within 24 hours of VA ECMO didn't really make a difference. But I would say that we really don't have data to guide us on one way or the other. And the complications I think we're all used to in terms of it not functioning, infections, or the hypovolemia or electrolyte shifts that can happen. So our approach is certainly much like anything in this patient population, multidisciplinary. CVVHD is the predominant mode. Our bias is to start early. I look forward to discussion with the panel about what that means. We start off with lower ultrafiltration rates, then guide it up based upon the preload as measured by the Swan-Ganz catheter. We leave the solute clearance and prescription to the nephrologist. And I think most importantly, improving arterial filling and reducing venous congestion with platforms to manage shock in terms of devices, which is one of the purposes of this conference, will give the kidneys the best chance to recover. Thank you.
Thank you. Yes, please. Use the microphone.
That was really excellent, Jerry. So one thing that you brought up at the very end is the rate of UF if you're going to do this in a pre-shock or a shock patient. And Jeff Tastani, who was mentioned by the excellent speaker from Florida, has really give us a lot of insights on some things. So one thing he taught us, and I don't know if he's proven it yet, if you UF at a high rate early, when the volume is a lot, you're probably going to be less likely to get into trouble than if you UF low and ramp up, because the shift in the volume is less likely in the first instance. So I'm wondering, do you think we should study that? Is there equipoise to study early fast UF, and and I have to credit Jeff Testani, who was a great fellow with us, early fast UF versus ramp up UF?
So I think it's a great question, and I think we don't know the answer. Studying this patient population, just given the heterogeneity, AMI or acute on chronic? All right, so acute on chronic, our patient population, in terms of indications, right, agreed upon criteria, and I would say not late, but in the context of refractory volume overload, medicines aren't working. Now, not needing renal replacement therapy with stable pH and electrolytes and just ultrafiltration, I think yes. I think we can create a homogeneous patient population, multi-centered approach, to see if a slower versus more aggressive is associated with improvement in outcome. But difficult to study. You know, this was a nice opportunity to go back and look at what was published, and some in the pediatric and some related to AMI. And at the end of the day, and I sit down with my nephrologist, they're like, well, this is our bias, this is how we do it. And let's start off slow and see how patients are tolerating it and ramp it up. So I think to answer your question, yes, difficult to do, and you have to have buy-in from a number of centers.
Well, I have a go. If you take an approach, the rapid study, when they used 400 cc for ultrafiltration, those patients didn't do well. And I think in CARES trial, the advantage of doing a step-up approach of medications was that you start to take off slower the fluid. And I think that's what we should be taking in account in terms of timing for CRRT. It's not when the patient is coming to the ED, but also we would have to be more aggressive on the way that we're looking at the patient in the hospital. I think one of the principal problems that we have is you start the diuretics to see the patient the next day, and you count what was the 24-hour shift. You should be evaluating the patient every 4 or 6 hours and see if the diuresis is what you are looking for, and step up the diuretic therapy. So when you reach the maximal of the diuretics that you can use, you can go to the next step. And I personally think we should start again slowly ultrafiltration and going up. Because I think faster ultrafiltration will cause more trouble for the patient.
So David, did you have a comment?
The question is, Jerry and also Dr. Missouri, what do you do with a patient who's got marginal urine output? Everybody knows what to do when the patients are responding to diuretic. Knows what to do when they're responding to diuretic, and when they're anuric, it's easy. But what about the fear that they're marginal? They're getting 100 an hour and then drips, and they're putting out 100 an hour, and you're getting nowhere. Be worried that if you put them on CVVH that you'll kill off their kidney completely, and maybe then you won't be able in your center to do a VAD, for example, if your surgeons don't like to do end-stage renal disease. Is there any evidence that using CRRT pushes a marginal kidney and kills it off, or is that just an illusion for us cardiologists that we need to ignore?
So I'll provide a brief comment and then defer to my colleague. So my bias is that it's looking at that patient and also knowing how high is the CVP, is there any acid-base disturbance, electrolyte abnormality? In other words, what is the likelihood of needing true renal replacement therapy in that marginal? If it's just venous congestion, otherwise stable, very high CVP, I'll push through pharmacologic. But with short duration to understand success, improvement in urine output measured in the next 2 to 4 hours as opposed to the next day. With that concern or fear that if I commit, maybe with challenges and shifting, that I may tip a patient over. So I don't think we know, but I think that's a discussion that needs to happen at the bedside with the intensivist, nephrologist, and cardiologist or provider, heart failure provider, to understand the pros and cons tailored to that individual patient profile above and beyond urine output.
There are a couple of questions I have. What about mixed shock? When you're talking about cardiogenic shock, there is going to be vasodilatory component. When there's congestion and vasodilatation, what are your thoughts on using vasoconstrictors and using dialysis or CRRT as a volume removal? That's the first question. The second question is, we face the situation of flogging the kidneys with continuous loop diuretic infusion with thiazides and cause profound hyponatremia. Is it better to just go for volume removal, especially in the context of post-LVAD RV failure where you want to keep the filling pressure down? Can you comment on those two?
Yeah, I think blood pressure is critical, both not only for the kidney, but for the other end organ functions. And so the hardest profile, in my opinion, is that vasodilatory and overtly congested. And I think if you're not maintaining perfusion pressure, you're going to run into problems, namely progressive renal dysfunction. I think that's clear. And so I think you have to improve vascular tone, try to understand the underlying reason. I think is probably most important, go after that, but use medicines. Which one medicine's best versus the others, I think that's a whole nother session. And then And so as it relates to banging on the kidneys and those that are diuretic resistance, my bias is if you're on, and we can talk about what it means, but if you're on high-dose loop diuretics with medicines that are enhancing sodium delivery for the loop diuretic to work, and the patient's becoming all uric and their CVP is still very high, I think you've reached your endpoint. And I think my bias is to go to ultrafiltration with all the caveats I mentioned in that particular patient. But I think, we reflect on our own individual experiences. I think this is the one area open to better understand just the basics, as Rami alluded to.